Right, welcome everybody. Can you all hear me? I'm Mike Cherry, I'm Professor of Zoology at SU, and this is a new way of meeting, but we're very pleased to welcome you on behalf of Stellenbosch University, and more specifically, the Faculty of Science's first online science cafe. So this is hosted in collaboration with SACIMA, the South African Centre for Epidemiological Modelling and Analysis, which is one of the centres of excellence in the Faculty of Science at Stellenbosch University, and also on behalf of the Development and Alumni Relations Division of Stellenbosch University. And we currently have between 60 and 70 people in the room. So before introducing the speaker, I'd like to share a few house rules. Firstly, we are recording this talk. Secondly, we're going to keep to 1 hour strictly. The speaker will address us for 30 minutes, and after that we'll have a Q&A session until 7 p.m. So please mute all your microphones and cameras all the time and address your questions to me in the chat section on Teams, and we will attempt to address as many of them as possible. So the topic for this discussion is modelling infectious diseases with applications to COVID-19, and we're very fortunate to have with us to address this Professor Prof Pulliam, who's a specialist in the modelling of infectious diseases. Juliet has been the director of SACIMA, which is a DSI NRF Centre of Excellence hosted at Stellenbosch since 2016, and her research focuses on applications of mathematical modelling to applied questions in infectious disease epidemiology, particularly in resource-limited settings. And Julia is also a member of the consortium of specialists convened by the National Institute for Communicable Diseases, which has been supporting the government and the Department of Health with weekly updates on the progression of COVID in South Africa. So in her talk, Professor Pulliam is going to provide an overview of how models can and can't be used to better understand emerging diseases, with particular reference to model results for COVID-19 in South Africa. So I suggest all of you pour yourself a glass of wine, imagine you're in Stellenbosch, and over to you, Juliet.
Thank you very much, Michael. And Luke, could we have the slides, please? About the history of SACIMA's involvement in modeling COVID-19 over the past couple of months, starting in late February, and then going through some of the work that we're doing now. Next slide, please. So I'll quickly give a brief COVID-19 status update. I'll then say a little bit about models in public health and some of their uses, and give a framework for thinking about how we go through the modeling process. I'll then talk about two different early models for COVID in South Africa, and then wrap up by talking a little bit about the National COVID-19 EPI model, which is a model that has been developed and is being developed by the South African COVID Modeling Consortium. Next slide. So as most of you probably know, the first sign that there was something going on that later turned out to be SARS coronavirus 2 or coronavirus disease was a ProMed report that was posted on the 30th of December 2019. It was at the time basically a cluster of undiagnosed pneumonia cases in China, and there was a request for information that went out to this wide network of epidemiologists who study emerging diseases. Since that time, it was eventually, about a month later, on the 30th of January, declared a public health incident of international concern, a public health emergency of international concern. And then in early March, the 11th of March, it was declared a pandemic. Next slide. So there's still a lot of things that are unknown about the virus. I'll probably highlight a number of them as I go through the talk. But one of the things that is still a bit of a mystery is exactly what the origin is. So Phylogenetic studies and what we know about coronaviruses in general tend to indicate that probably there is a bat reservoir. However, there's a lot of speculation that there may have been an intermediate host, meaning another species that bats transmitted to, where the virus underwent potentially some sort of genetic changes, which then helped it make the transition to infecting humans. Next slide. And there has been a lot of speculation that it might be traced back to the Wuhan animal market, which is a wildlife market in Wuhan, the city where the first cases were discovered. But I think that is still very much speculation and can't really be proven. Next slide. So this is the current situation in South Africa. On the right-hand side, you'll see the latest COVID statistics from the Department of Health. And we currently have over 55,000 cases that have been identified. So those are detected cases, meaning that people have been tested and they've tested positive. Over 2,400 of those were tested positive in the last 24 hours as of yesterday. So this is the numbers from yesterday. And there have been over 1,200 deaths. I apologize if you can hear my dog. They're very upset about the situation. So on the left-hand side, you can see a timeline for the cases and the deaths. So this is showing the total confirmed cases on the top and the total confirmed COVID-19 deaths on the bottom, both for South Africa. And what this is showing is essentially that there is an ongoing increase. There's no sign that the growth is slowing down. And this means that we're basically still in the very early phase of our epidemic. And we expect that over the next couple of months, we're going to see a surge, and the numbers of cases and deaths will continue to increase. And I'll say a little bit more about that later in the talk. Next slide, please. So before I start talking about models of COVID in South Africa, I would like to talk a little bit briefly about models in public health more generally. Next slide. I don't know exactly who the audience is. Next slide. But some of you may think of modeling as something that looks like this. Whether this seems comprehensible to you or whether this seems like a big something you want to run away from, this is the type of modeling I'm talking about. So generally, mathematical representations of simplified assumptions about a system that are a tool for helping understand. Next slide. Those of you who are think of modeling as this are also welcome in this talk, and I am going to try to keep the language and the explanations at the level of someone who thinks of modeling more as the latter than as the former. Next slide. Okay, so when I say modeling, what I really mean is applied epidemiological modeling. Next. So epidemiological is a big word, and what it means is related to the distribution and determinants of health-related states and events. So it basically just means that we're trying to understand when health and disease occur and where they occur in a population. Next. The modeling part is really the use of simplification to represent the key components of something that you're trying to understand more clearly. So modeling is a tool that we use to help us think about a problem, and often to help us think about the future, but also sometimes to help us think about the past or to help us think about really any sort of problem. So we have epidemiological modeling. So using this tool of simplification and abstraction to understand the distribution and determinants of health-related states and events. And then the applied part next is just basically saying we want to do this in a way that's applicable to the real world. Next. So this is the framework that we at SESIMA use to think about modeling. So we have essentially three distinct quantities. So we have the real world, which of course is what we all live in, or most of us live in, where we try to live, where there's lots of interacting parts, there's many different things going on, and usually you can only see a very small part of what's going on. And then as modelers, one of the key steps in the modeling process is abstraction. So we take what we know about the real world and we try to distill out what are the most essential features of the real world to address a specific question or to solve a specific problem. And so we take all the mess that is the real world, put aside the things that we don't think are important, and then create what we call a model world. So a model world is something that we can then start to think about in terms of what are the properties, what should happen if this happens, what would I expect, and what are the key sort of interacting components, how do they interact, etc. So we try to sort of conceptualize this model world, and then once we understand sort of what the assumptions are that we want to make, then we formalize that through implementing a model. And that usually means either writing down some equations or writing some computer code or some combination of the two. So once we have a model that we've implemented, we can then start to manipulate it. We can change the values that we've put in, or we can even change the structure, and that sort of iteration of adding in complexities one at a time, looking at what happens, how much an outcome that we're interested in changes as a function of different values that we put in, that gives us understanding. But what that does is it really gives us understanding of the model world. So it allows us to understand under this set of assumptions, what is the behavior of the system? What are the expectations? And then because we're interested in applied epidemiological modeling, there also has to be an interpretation step where we take what we've learned about the model world and try to then think about what it means for the real world. And there are different people involved at different stages of this process. Typically, the sort of iteration back and forth between the real world and the model world are done by a combination of modelers and either decision makers or other researchers or stakeholders of some variety in addition to the modelers. And then the iteration going between the model world and the model itself is usually done by the modelers. And so this is the whole process that we undergo every time we start thinking about constructing a new model. Next. So I'm going to talk about I'm going to frame things a little bit in terms of this process and talk about the early models for COVID in South Africa that CIMA was involved in. Next. So the early models that I'll describe are really tools to improve situational awareness. They were done in early March, late February and early March, were when we were working on these, and we were really just trying to give an improved understanding of what the situation could be. Next. So I'll talk first about what I call the initial estimates, and then I'll move on to talk about some short-term projections that we made earlier on. So next. So on the 28th of February, we received a request from the National Institute for Communicable Diseases to provide a rough estimate on the potential health impact of the COVID-19 in South Africa. We agreed to try to do an initial assessment with the understanding that these would be very crude initial estimates because there was very little data at the time. Next. So then we began this process of thinking about, okay, what's the real world question? What model world can we construct? How do we formalize that in a model? And then going back. And so I'm going to try to take you through these steps next. So when you're developing a model world, one really important thing to keep in mind is that when you have a data limited situation, you really require a simple model. You can't build a large complex model if you don't have any information about the system. So we started thinking about what are the key elements. So what do we want to represent in this model world? We came up with basically 3 key elements. The first is how many people would be infected. The second is how many people would seek care, various different types of care. So some of those people might have to be hospitalized, some might seek outpatient care, but we felt that the potential health impact would be represented in part by how people interact with the healthcare system. And then the third element that we wanted to look at is how many people would die. Next. So of these elements, we decided that how many people would be infected was unknowable at that stage. So this was, as I said, late February, early March. So the situation in China was still not resolved, and other countries around the world were just starting to see cases, and it was clear that it would be spreading, but there was really not any information about how broadly the population would be infected, and it was not even clear, and all of the opportunities that could have given some insight into that question were very much influenced by the interventions that were put in place. So there were basically two settings that we could look at. So there was China, where of course they had a very strict lockdown policy, and there was the Diamond Princess cruise ship, which I'll talk about again in a little bit later. But that again was a situation where very early on in the outbreak, they were put under quarantine and everyone was kept to their rooms, and the people who were infected were removed from the boat. So neither of those situations really seemed to give much information about what proportion of the population would be expected, or the population level attack rate that you would expect at the end of an epidemic. So we decided that would be treated more as an input into our analysis, and that we would do a scenario analysis looking at different levels of population level attack rate. So that allowed us to reframe the question, and basically ask, if a specified proportion of the population became infected, how many people would seek care and how many people would die? And in walking through this, I'm going to focus on the question of how many people would die, but I'll also show you where you can go if you're interested in seeing the rest of the analysis. Next. So what was known at the time? So one of the things that we knew was that not everyone who's infected has symptoms, and that is a really important aspect of this disease that is sort of new or different, not necessarily expected in a pandemic. We also knew that the proportion of cases who die depends very strongly on age. So that had become clear at that stage based on data out of China. When I say cases, I mean people with symptoms. So I try to distinguish between cases who have symptoms and infections who may or may not have symptoms. And we also knew, and this is something we've known for a long time, that early case fatality estimates are biased. So there's a number of reasons for that. One is that that it takes people a while to die. So you can have people recovering at a faster rate than people dying, and that will bias your estimate. There are other reasons as well, but so these were sort of some of the working knowledge that we had in trying to construct our model. Next. Okay, so I mentioned that that we knew that not everyone who was infected would show symptoms, and we knew this pretty well from the Diamond Princess cruise ship. So there were 634 people infected on the Diamond Princess cruise ship. Next. And as an estimate that had been published, well, actually it hadn't been published yet. It was in preprint at the time. But there was an estimate that had been made that about 18% of the infected people had no symptoms. And so that is a relatively high, or we thought at the time that was a relatively high asymptomatic proportion, or proportion of people who have no symptoms. And we thought that was definitely worth taking into account in the construction of our model world. Next. Okay, so at the time, we thought that about 18% of infected people would have no symptoms. Next. So we were looking at a flexible approach to look at many different scenarios, and we ended up with this set of inputs. So first, the number of people in the population by age group, which I'll denote N sub I, where I is the age group. The proportion of people who will become infected, which is the attack rate, A. The proportion of infected people who don't show symptoms, that's the asymptomatic proportion, which I'll show as P sub A, and then the age-dependent case fatality estimates corrected for known biases. So this is F sub I, again, because it varies by age group. Next. So putting these things together gives us a very simple model of how we can calculate an expected number of deaths for a given age group. So essentially, we take the number of people in that age group, we multiply by the attack rate, which is the proportion of people who become infected. We multiply that by the proportion of the people who will have symptoms, which is 1 minus the asymptomatic proportion. And then we multiply that by the case fatality rate, which is the proportion of people of symptomatic cases who will die. Next. And then overall, we get the total number of deaths by summing up over the age groups. Next. So we can get values for most of these different parameters. So the population data we were able to get from the mid-year population estimates from Statistics South Africa. Next. The attack rate, as I mentioned before, was an unknown parameter that we treated as an input and varied to get different scenarios. Next. The asymptomatic proportion, as I said before, was estimated from the Mizumoto paper at about 0.18. Next. And then the age-specific case fatality ratio was estimated from 2 different sources. So this was, again, a type of sensitivity analysis. We used one source published by Ru et al. That accounts for underreporting. So basically, the fact that that severe cases are more likely to be detected than more mild cases, and therefore you're more likely to see people who die than people who don't die in your counting. And they also accounted for the time delay to death. And the second source that we looked at was a paper published by Tim Russell et al. And they used data from the Diamond Princess to adjust the age-specific fatality rates from China, and therefore to come up with another an alternative set of age-specific fatality rates. Next. So this is a set of results that you might get out of this model. So showing a sort of two-way sensitivity analysis. So this is showing, assuming the asymptomatic proportion from Mizumoto, we have a variety of different attack rates, and then estimates of the number of deaths that you would get under those attack rates. And as you can see, they vary widely. So the Russell estimates give you lower numbers than the Ru estimates do. And as you would expect from looking at the form of the equation, the expected number of deaths increases linearly with the attack rate. Next. And so that was for the Mizumoto estimate of the asymptomatic proportion. More recent estimates have been higher. So there's a paper by Emery et al. That estimated an asymptomatic proportion at 0.74. And then that again changes the estimates that you would get of the attack rate. That Emery paper was published much later, so wasn't considered in our initial sensitivity analyses. But essentially what I'm trying to show is that we can take this very simple approach and get a wide range of estimates for what the fatality, the number of deaths from the pandemic might be under different scenarios. The tricky part is the attack rate, because that's really unknown. And so at the time, we were thinking that that our sort of primary estimates would have been about a 20% attack rate, because that is the attack rate that that influenza in South Africa has every year. Every year, about 20% of the population is infected with flu. And flu being a respiratory disease with a fairly similar, it seemed at the time, fairly similar epidemiology, that was our best guess. Now, there are definitely reasons that it might be higher than that, for example, because this is a novel pathogen and everyone is susceptible, whereas for influenza, a large proportion of the population it has seen influenza before and may not be susceptible. And there are other reasons as well, but right. So at any rate, in response to this request from NICD, we presented a wide range of different scenarios with different parameter values that were sort of mapping out the range of what could be the case for the fatality estimates. Next. So if you're interested in learning more about this approach or seeing how these numbers change for yourself, or looking at provincial estimates as opposed to the national estimates, there is an interactive app that you can go to on the web. This is the URL, and you can also download the code there if you have an interest in seeing how that works. Next. So there are a number of strengths and weaknesses of this model. I think that some of the strengths are that it was simple and flexible, and it allows uncertainty to be explored in a setting where you have very little data. I think that's really important. And I think also the assumptions are very clear and it can be implemented very quickly. So those are the main strengths that I see. The limitations became clear very well. I think even as we were doing it, we were aware of the limitations. But one of the main limitations, and the one that really became sort of the motivation for the next thing that we did, was that there was no time scale associated with cases or deaths. So we could say, okay, if 10% of the population gets infected, this is what we expect in terms of cases and deaths. But that doesn't give us any ability we had no way to say that's going to occur over the next 6 months or that's going to occur over the next 3 years. The model simply doesn't allow us to do that. And that was the next question that we kept getting was, okay, this is an estimate, but like over what time frame? How long do we have to prepare, et cetera? And then some other limitations are it assumes a level of care comparable to Hubei province in China, and does not account for potential differences in comorbidities. So there's a lot of complexities that we weren't taking into account. Next. Okay, so I said one of the main limitations was that there was no temporal component, and so the next set of projections that we started working on were short-term projections to try to get an idea of how the epidemic might take off in South Africa next. So the question was posed on the 13th of March of when do we expect to see the first 1,000 and first 10,000 cases? And we interpreted this question as as being framed in terms of, if nothing changes, when would we expect to see the first 1,000 and 10,000 cases? Next. So again, we went through this process of trying to understand what are the key things that we need to be representing, and then how do we formalize that into a mathematical framework, or in this case, more of a simulation code framework. Next. So we were still in a data limited situation, and so again, chose to use relatively simple models. The initial estimates that were available for the basic reproduction number and the time between successive cases were available by that time. So those were two of the key key building blocks in the model that we developed. In addition, no interventions have been put in place at the time. So this was early March, before there was any talk of a lockdown or even of border closures or anything of that sort. And the virus had already been introduced. So I think at the time that we were working on this, there were about 23 or 24 cases that had been detected in South Africa. So next. So we took an approach using what's called a branching process model. And basically what it does is it takes the what's called an offspring distribution. So basically every case has a probability distribution for how many offspring or how many new cases it will generate. And so for each case, there's a random draw from that distribution. And then there's also a serial interval distribution. So the serial interval is the time between when one case shows symptoms and when the next case the case that it infects shows symptoms. And so for each pair of cases, then we can draw a serial interval. So this is a stochastic model that allows us to show a lot of variation just through the stochastic process, and to build up an idea of what different epidemic trajectories might be possible. So we seeded introductions on the same timeline as the known infections, and assumed a constant detection probability with about half of infections being detected. So we recognized that the introductions that were already identified were probably not transmitting a lot. They had been isolated. However, we were essentially making the assumption that about half of the cases would be missed and would continue to be missed, and that those cases would go on to transmit. And then we also assumed that the epidemic trajectory would continue without substantial intervention, not because we thought that there wouldn't be an intervention, but because we wanted to say what would happen if there were no intervention in place. Next. Okay, so this is the output of this model. So on the top here, so along the x-axis, if you can see it, I'm having trouble seeing it. Along the x-axis is the dates. So starting in mid-March and going forward. The top panel is showing the cumulative cases with simulated trajectory. So each of those black lines is one simulation. And then the red and the yellow summarize the red and yellow bands on the top panel are summarizing the middle 50% and the middle 90% of those simulations. So we can read this as saying, in the absence of interventions that change the epidemic trajectory, the cumulative case count is next likely to reach 1,000 cases between the 28th of March and the 2nd of April. when we say it's likely to reach that, it means there's a 50 based on this model, there's a 50% chance that it will reach 1,000 cases between the 28th of March and the 2nd of April, and a 95% chance that it will reach 1,000 cases between the 25th of March and the 9th of April. And you can see on the bottom panel in yellow, that's the distribution of different times based on those simulations. And then similarly, next. Sorry, and I did want to point out that that prediction was accurate, that we reached 1,000 cases on the 28th of March, when the total number of cases increased to 1,070. Next. So then the same thing for reaching 10,000 cases, we could say that in the absence of interventions that change the epidemic trajectory, we would be likely to reach 10,000 cases between the 11th of April and the 16th of April. Of course, what happened in between is that on the 27th of March, the national lockdown occurred, which of course violates the assumption of no interventions and would change that expectation. Next. Whoops, sorry, can you go back? So it actually took until the 11th of May before there were 10,000 cases, and I interpret that as largely being a result of the lockdown. Next. Okay, so again, this approach has strengths and weaknesses. So it provides a probabilistic view of the likely epidemic trajectory in the short term. Again, it has clear assumptions and allows quick implementation, but it also has serious limitations. So it assumes a constant epidemic trajectory. It doesn't allow us to account for changes in policy interventions or other types of behavior change. And it assumes a constant detection probability, which of course was probably changing as well. And so we consider this this approach to be useful in the short term, but definitely not something that we would want to use beyond a few weeks early on in the epidemic. Next. So that's the summary of the early models. As I said before, they're tools to improve situational awareness. And the key takeaways from this part of the talk are that data-limited situations require simple models. Models can help assess and understand the impact of uncertainty. So that's a lot of what these early models were about. And also highlighting that a changing situation demands different models at different stages. That's partially because the questions change at different stages, and partially because the amount of data and information available change at different stages as well. Next. Okay, so now I'm going to move on and talk about the national COVID epi model. Next. And this is more of a tool to improve resource planning. So before I was talking about tools to improve situational awareness. The national COVID epi model is a model that has been developed specifically with the goal of helping with government and other players with their resource planning. Next. So this is work done with a great number of collaborators. So the primary collaborators are Sheetal Silal, who is the director of the Modeling and Simulation Hub Africa at UCT. A great group of people from HERO, the Health Economics and Epidemiology Research Office at WITS, and Harry Moultrie, who is the coordinator of the South African COVID Modeling Consortium, and he's based at the National Institute for Communicable Diseases. Next. So the South African COVID-19 Modeling Consortium is a group of researchers from academic, nonprofit, and government institutions across South Africa. The models that I'll be talking about have been developed by Masha, Sasima, and Hiro in conjunction with the NICD as the core modeling team, but has also been informed by extensive and ongoing input from clinicians, virologists, intensivists, and epidemiologists to refine key model assumptions and parameters. Next. So there's actually two national COVID models, and the one that I have primarily been working on is the EPI model. There's also a cost model which uses the output of the EPI model along with a wide range of other inputs relating to resource requirements to try to cost the ingredients of the response. But the national COVID-19 EPI model is a generalized SEIR model. So basically that means it's a compartmental model that represents people in a number of different mutually exclusive states. And these states are representing different levels of disease severity as well as people moving through a treatment pathway. So we have a representation of asymptomatic individuals, mild, severe, and critical cases, and then also these severe and critical cases may enter hospital and may or may not require treatment in the ICU, the intensive care unit. Together, these two models are used to inform resource requirements and predict where gaps may arise based on available resources. Next. So the current model has a number of limitations, and I think it's important to have this context for interpreting the model output. So first of all, projections at the population level are not capturing clustering of cases. The specific events like funerals or church events that have caused a large number of cases are not directly captured in these models. The current version of the model projects total need for hospital and ICU beds, basically assuming unlimited capacity, and therefore doesn't take into account any additional mortality, any excess mortality that might occur because there is a limited capacity for hospital and ICU beds. The model also doesn't account for changes in population behavior, so it does have some changes in behavior in it that are sort of associated with different levels of the lockdown, but there are other ways that people often change their behavior, for example, in response to mortality, that are not included. The projections will improve with new data, and we've been working hard over the last couple of weeks to start using to be able to parameterize aspects of the model from local data, particularly on hospitalizations. And there's substantial uncertainty regarding both the true scale and spatial distribution of cases as a result of changing testing criteria and coverage. Next. Okay, so using the national COVID EPI model, we've looked at two scenarios, and these scenarios that I'm presenting are based on what is in our reports, which were published in which were published in May, and both of those reports, there was one for national projections and one for provincial projections. Both of them had the same set of structure of assumptions. So we assumed that level 4 would last until the 31st of May, followed by continued physical distancing and other non-pharmaceutical interventions. We had an optimistic scenario, which assumed that lockdown reduced transmissibility by 60% relative to the baseline of no intervention, that level 4 reduced transmissibility by 35%, and that after that, transmissibility would be reduced by these other measures by 20%. And then our pessimistic scenario assumed that lockdown reduced transmissibility by 40%, that level 4 reduced transmissibility by 25%, and that after that, transmissibility was reduced by 10%. Next. So the current question that we have been focusing on is how long do we have to expand ICU capacity before current capacity is exceeded? Next. And the approach that I'm going to take here is based on the information that was in the reports that we put out in May, and basically sort of comparing some of the projections in those reports to the current situation to try to sort of update the situation. So what I've done is compare detected cases on the 1st of June to predictions under the optimistic and pessimistic scenarios, that, allowing me to assess the current trajectory, and then based on the current trajectory and the long-term projections, evaluate the likely time when capacity will be breached by a province. Next. So here's an example for the Western Cape. These on the left-hand side, you'll see the optimistic in blue and pessimistic in red projections for from the provincial report for ICU beds in use as a function of time. And you can see the ICU bed threshold, I think it's around 450 beds. The number of cases on June 1st was, for the Western Cape, was 22,567, which falls within the range of the pessimistic prediction, which is the red. So then you can go, you can look over at the left-hand side of that figure and see that under the pessimistic prediction, we expect to be breaching ICU capacity in early June, or perhaps as late as mid-June. And that is consistent with what's been seen in the hospitals. Certainly in the public sector, the capacity, the ICU capacity has already been exceeded. And they've been working hard to expand that capacity and also working out ways to transfer patients to the private sector. Next. So this is a summary going through all of the different provinces of what the current trajectory looks like. For most of the provinces, we are more on the optimistic side of things. Then given what the current trajectory looks like, when we would expect the bed capacity to be breached, it's worth noting that even for the trajectories or for the provinces that are on the optimistic trajectory or doing even better than the optimistic trajectory, like Gauteng and Free State, we are still expecting that bed capacity will be breached. It will just be breached later. So Western Cape is the earliest in early June. Eastern Cape, which is doing worse than pessimistic, is expected to breach capacity in mid-June. Most of the other provinces are expected to breach capacity sometime in July, although it could be later for Gauteng and Free State. Next. So the next steps that we're working on with the national COVID epi model is really, we finally have enough local data. I guess it's not a good thing, but there have been enough hospitalizations and deaths that we're now able to use the local data to parameterize the treatment and mortality pathways. So we'll be, we've done that, and we'll be releasing a report soon that incorporates that. And we are also now accounting for excess mortality due to exceeding hospital capacity, which is something that was not included in the previous report. Next slide. So for more information about the approach of the South African COVID Modeling Consortium or the National COVID Epi Model, and for additional results, this is where you go to find them. You can just Google NICD surveillance reports. That's, I think, the easiest way to find them. And future updates will also be posted on the same website, and they're listed under the Modeling Consortium. Next slide. So the key takeaways are that, again, a changing situation demands different models at different stages. I think I've emphasized that already. Models help decision makers plan in the face of substantial uncertainty. So in this setting with the example from the national COVID epi model, we have those different scenarios as sort of benchmarks because there is substantial uncertainty in terms of how things are going to proceed, and people need to be able to make decisions in the face of that uncertainty. And then I hope it's clear that models get updated as new information becomes available, and of course, as new questions become relevant. Next. Okay, so that's all I really wanted to say this evening. I would be happy to take questions. Thank you for listening.
Well, thanks very much, Juliet, for a very lucid description of how you derive these models. So I've sat in many modeling seminars in my time, and not all of them are as well described as this, believe me. So I'll remind you now to please direct your questions through the chat function. There are now over 100 people in the room, and I'd like to start off with a general question. So the columnist Neva Machetla, writing in Business Day last week about models, said, we should be careful to understand what the utility of models is, that we shouldn't feel constrained by models. Their aim is to set upper and lower limits to help in planning. But as you yourself have acknowledged, that the intrinsic problem with models is that it's difficult to actually account for behavior change. And I wondered if you'd like to, and particularly people shouldn't be fatalistic about models because, of course, we want to encourage behavior change. So I wondered if you'd like to comment a little bit more about that.
Sure. I think behavior change is something we've been talking about a lot over the last couple of weeks. And frankly, I think many of us have been talking about it for longer because it came up over and over again in Ebola modeling, and it comes up again in HIV modeling. And I think it's something that's really hard to grapple with because it's something where it happens, and you know that it can have a really big impact on the trajectory of an epidemic. And you actually want to encourage that if that's something that models can do, but it's very hard to quantify, and it's very hard to know exactly what the mechanisms or what good descriptions there are for that behavior change. And so I guess that's sort of where things get stuck. And so there are different ways that people can incorporate or have incorporated behavior change into models. So you can make an assumption that people are responding to mortality. You can include that response as being driven by sort of what's happened recently. So in that case, you end up getting oscillations, because if people are paying attention and they say, oh, there's a lot of people dying, I'm going to change my behavior, and then people stop dying at the same rate, and then they go back to their previous behavior, that creates oscillations. If, on the other hand, they're observing that observation of mortality in a more instantaneous way, instead of just looking back over the last month or the last few weeks, then that actually has a different effect on the shape of the curve that is produced. So you end up with a long plateau, which is something that is being observed in some countries at the moment. There's also, you can make assumptions about there being not so much behavior change as in individuals changing their behavior, but but changes in who's getting infected because some people already normally behave differently from others. And so if you have a heterogeneous population with some people interacting with a lot of people, those people are more likely to get infected early on, and then and then once they've been infected, they are going to sort of represent an immune node in the network of infections, and so they actually sort of dampen the transmission later on. And so I think we think about it a lot. There's lots of ways to think about it and to incorporate it, but it's a really hard nut to crack because it's very hard to measure. It's very hard to know how people are actually going to behave.
I have a short question from John Measy. He asks, do you have some idea of the current value of PA? So in other words, the current value of asymptomatic people in South Africa. So PA it would be a little more general than in South Africa. So PA is the proportion out of all of the infectious or all of the infected people, what proportion do not have symptoms. The estimates are really, really variable. So I mentioned two estimates. The first one that I saw was that estimate of about 18%. And since then, most of the estimates have been much higher, up to around the other one that I quoted of 74%. The WHO just recently, I think in the last day or two, made a statement about this, a somewhat confusing statement about this, because they were also trying to make distinctions between truly asymptomatic individuals and pre-symptomatic individuals. But I think the estimates are converging maybe somewhere between 40 and 50%, is my current understanding. There's another question from Gottlieb van der Merwe. He says that, you showed that the initial lockdown was successful in lowering the rate of transmission, but that the subsequent relaxation to level 4 has not had any noticeable effect on the progression of the pandemic. In other words, the transmissibility has been unaffected. So has the model been calibrated since the predictions from the field data in terms of the effectiveness of the lockdown measures?
Yes, so we're in the process of putting out our next round of reports, and exactly in this new round of reports, we are calibrating to the level 4 lockdown to be able to better capture the actual dynamics that were observed. I hope that answers the question.
There's a question from Brian van Vilken. He says your projections show that the Western Cape are going to run out of ICU capacity in a week or so, and then we're going to return into capacity in a month or two. And he asks, why will we return and not stay out of capacity as the disease spreads?
So if I'm understanding the question correctly, so the curve goes up and then it goes back down. And as the disease spreads, we will stay out of capacity. And our projection is that it takes about 2 months. If that, I don't have the figure in front of me, so but I think it takes about 2 months to go up and then go down. But all that time in between, we would be exceeding capacity. And so when it goes back down below capacity, that is basically saying that the epidemic has run its course within the Western Cape.
So there's a question from Dr. Bartlett. He says, will the modeling consortium release the source code for the EPI and cost models, not merely the reports, but the source code?
So I would like to do that. We have a lot of controversy over this. So the consortium is coordinated by the NICD, and we have to have our understanding is that we have to have permission from NICD and from the National Department of Health before we can release anything. And so we have been working on getting the code ready for release, but we haven't yet been told that we can release the code. It's under a non-disclosure agreement at the moment.
Right. So a question from Dieter Winkler. He says, thanks very much for the wonderful presentation. On the slide before the slide of the Diamond cruise ship, how is it that the case fatalities were biased?
So, I need the presentation in front of me. Sorry, I do have it on my computer. The slide before the cruise ship. Right. Okay. So there's two main ways that that early case fatality estimates can be biased. So one is essentially under ascertainment. So early on in an epidemic, before you have a really good understanding of the spectrum of illness, the cases that tend to get detected are the more severe cases. And so because you're seeing the more severe cases, more of them are dying, and that biases your estimates of the case fatality up. And then there's another bias which actually goes in the other direction, which is that the duration of or the time from onset of illness to recovery typically, and in this case, is shorter than the duration of time from the symptom onset to deaths. And so that means that if you're just looking at a point in time and you're saying how many people have died out of all the cases, or how many people have died out of the ones that have died that have a known outcome, then you're undercounting your deaths. And so the biases pull in different directions, but they're both there, and you have to use sort of more sophisticated methods in order to be able to tease them out and think about them, how they might balance out each other out or pull in more in one direction than the other.
Well, Juliet, I think we're running out of time, and so we're going to stop this recording now. Those of you who'd like to receive the recording, please indicate that on the chat function. And it just remains for me to thank you very much for a very, very interesting and lucid presentation. And I hope this won't be the last Stellenbosch online science cafe. But thanks also to everybody who helped to arrange it and get it organized.
Thanks so much, Michael. And thanks for everyone for attending.
Right. Okay, I'm going to end the meeting then. Cheers.
All right.
Thank you. Thank you, Juliet. Thank you, Prof. Mark. Thank you, everybody. And for those who are staying on the call, please feel free to enjoy your refreshments.